Okay. All right, so what I wanted to do was go through some things that were in the videos. Hopefully you've already seen them. If not, you really do need to see those on YouTube that we posted. But things that are highlights, things that you really need to know, because they do ask questions about these things on state exams and our exams and that sort of thing. So I just wanted to hit some highlights. So we'll go through it pretty quick. I'm going to go through the slides pretty quick. Obviously, children differ. A lot of people think they're just small adults. They're not. There's a lot of differences in kids in physiology and anatomy, and obviously psychology. And so some of the differences we obviously need to know. One of the big ones is their heads are a lot bigger. And so you can see how this kid's head is flexed, and that can compromise an airway. And so what we need to do is to put like a folded up towel or something underneath this kid's shoulders, so that allows his head to drop back. Now, we don't want it to drop back too far either, because it can go the other way because they're so pliable in their throat. So obviously the mouth and nose are smaller, they're more easily obstructed. The tongue is larger in proportion to in their throats than it is for adults. So it's easier for the tongue to cause airway issues, or for things in there, because the tongue takes up so much space. They don't need a lot of stuff in their mouth to cause an airway issue. Kids, especially when they're really young, are nose breathers. And their trachea is softer, and it can get kinked either way, depending upon how we flex or extend the head. Babies, the ribs are more box-like, so it's a limited ability to take a bigger breath. If you do need a suction, again, because the smaller the kids are, especially infants, they're nose breathers, and we'll talk about that briefly when we talk about OB. But start by suctioning the nose and then suction the mouth. And again, hyperextension or flexion of the neck can result in airway obstruction. The big thing we've talked about we talked about environmental emergencies, but more of their body is on the outside compared to an adult. So the ratio of mass to surface area is a lot less than it is in an adult. So they can get hypothermia a lot easier because they're going to lose more heat through radiation through their skin than an adult will. They have less blood volume. You can have one of the terrible calls I went on many, many years ago. We had I don't even remember now how it happened, but a baby had a glass baby bottle and got cut and bled to death before I got there. They didn't know how to stop bleeding. These parents didn't. And a baby or a very, very small child maybe only has enough blood that's the size of a Pepsi can, 350 milliliters. Whereas adults, we have a lot more blood. We have 5 to 6 liters, usually around 5. But they just have the amount of blood that's in like a Pepsi can. As far as respiratory assessment, when they're having difficulty, some of the things that we see in kids that we don't always necessarily see in adults, nasal flaring, we did talk about that. When somebody's laboring to breathe, sometimes their nose flares out. We especially see that in kids when they're struggling to breathe. Retractions, that's where the muscles, intercostal muscles, the muscles between the ribs hollow in, and when they're trying to take a breath in. And they use abdominal muscles. Stridor, they get a high-pitched, harsh sound when they breathe. And that's usually from an upper airway type of obstruction, like in the larynx or somewhere like that. Kids wheeze, and they don't even necessarily need to have a stethoscope to hear them wheeze. It's called sibilant, when you can hear something without using a stethoscope. And you can hear them wheezing when you walk in the room quite often. And especially the younger kids, they'll grunt when they breathe. It's a grunt sound, and they're really forcefully trying to exhale and keep those airways open so they can exhale. Kind of like creating a bit of a back pressure to try to maintain that airway being open. Um, if they're breathing more than 60 times a minute, we're talking littler kids. Babies will breathe 60 times a minute. Okay, that's normal. But the kids, if they're having respiratory distress, you know, the toddlers and people like that, if they're breathing more than 60 times a minute, that's an issue. It really gets to be an issue if they start having altered mental status. And it's worse if their respirations start going downhill rate-wise, or if it's irregular. And it's very rare to have an irregular respiratory rate for anything. We do see them. We see them in strokes and some head injuries and things like that. It's rare in kids, so if you see it, that's an ominous sign. You've got something really bad going on. Another ominous sign is the blue color cyanosis. And then if they get flaccid. And poor peripheral perfusion. So how do we measure peripheral perfusion in a kid? We do a capillary refill test. So we blanch out the nail and let go, and it should turn back to red by the time we say capillary refill test. That's about 2 seconds. If it comes back, but it's longer than that, then it's delayed capillary refill. And if it doesn't come back for quite a bit, then that's no capillary refill. So that's a sign of poor peripheral perfusion in a child. This capillary refill is not that reliable in an adult. Fingernail polish. Some people have already have some sort of perfusion disease, like a Raynaud's disease or something, where they don't have good perfusion of their fingers, or if it's cold outside, that'll alter it. And then obviously if their heart rate starts going down, because again, remember, the younger we are, the faster our heart beats and the faster we breathe. And as we get older, they both slow down. So a real common thing that we see and we get called for is croup. Now, croup is, the younger kids get croup, and it's also called laryngeotracheal bronchitis. But the 3 months to 3 years of age is where we normally see this. They'll get a fever, they'll sound hoarse, they get that seal barking sound cough, okay? They may have some difficulty breathing. I'm not sure what signs of respiratory breathing means. They may get a little restless. They could be pale. Hopefully they're not cyanotic. And croup is a viral illness. Lots of times we see this when it comes wintertime. If they're inside, the house has been dry, and they get this viral infection, and they start having all these issues. And then we show up and we take them outside to the ambulance, and it clears them up, that cold air, for some reason. It happens quite often. But croup is something we do see a lot, and you would treat them like any other respiratory problem: airway, breathing, circulation, oxygen if their pulse ox is down, etc. Some people, doctors will tell them, you know, run a cold shower and mist it up, and have them, you know, in the bathroom next to the shower, and breathe in that humidified air, and it's colder and might help them reduce swelling from the infection. The worst thing that we'll see is something called epiglottitis. Unfortunately, we don't see it a lot, but it does happen. These are a little bit older kids. They'll get a higher fever than somebody with croup will get. And what's happening is their epiglottis is infected, and it's swelling, and it's partially blocking that airway. It's a bacterial infection, so they're going to get a decent fever. They'll have trouble swallowing because, again, the epiglottis is covering the larynx. And so food or fluids have to go past it on the other side into the esophagus. So they're often drooling because it's all swollen in there. They'll get positioning because they're trying to be able to move air in and out. And they look a lot sicker than a kid with croup would have. This is very, very serious. This is life-threatening. With these kids, we want a nice, gentle transport. Don't bounce them around. Don't make them upset. Don't put anything in their mouth to look in their mouth. You know, don't get a tongue blade out and see if you want to see, you know, their epiglottis, because you can't. Just very gentle transport, okay? And by the way, with kids, we never, ever, ever anymore are allowed to have a parent hold a child in the back of our ambulance. You have to use a pediatric restraint device. That's the protocols, okay? Like something like a PD-NATE or something similar. Long gone are the days where we just have mom hold the kid to keep him quiet and have her belted. When you get in an accident, the kid goes flying. Use their car seat or some other pediatric restraint device. So dealing with kids is tough. These are some of the worst calls that we go on when you have a bad kid or you get a kid that's been hit by a car, a SIDS case, things like that. I remember a SIDS case when I was working ER coming in, and they came running in from the ambulance garage carrying this kid, and he was wearing the exact same pajamas that my son of the same age wore. And it's like, ooh, freak you out, you know? So it gets very, very emotional. So we go from some of the calls that are worse that we're gonna see to some of the calls that are, at least for me, fun. I like delivering babies. I've probably been involved with almost 24 deliveries between field, training, my own kids, etc. So let's go through some stuff here. Some of the things you have to know is the anatomy of pregnancy. So the vagina is the birth canal, it's smooth muscle, it's a tube. We have ovaries that release eggs, and then the fallopian tubes that carry those eggs down into the uterus. So the ovaries produce the eggs called ova, and the fallopian tubes are the ducts. Now this is where fertilization usually occurs, and it becomes important here in a second. I'll tell you why. It's because of something called ectopic pregnancy. The other structure is the uterus. It's a muscular hollow organ. And again, this is where the now fertilized egg will implant. So in the picture, fallopian tubes, egg gets released, it gets fertilized somewhere in here, and then comes down in here and then implants on the endometrium or the inside wall of the uterus. Now, I want you to pay attention here because these are blood vessels and they run right alongside the fallopian tubes. If you have a woman that has had maybe infections or has had some disease process of some kind, maybe has ovarian cysts that have grown, and that egg gets fertilized but gets stuck in this tube because of scar tissue, pressure from this ovary pushing on it, something like that, it'll start to grow here instead of down on the wall of the uterus. And that's what we call an ectopic pregnancy. Ectopic means coming from someplace it's not supposed to. Okay. So as it grows, it's going to eventually eat into these blood vessels and they're going to rupture. And then mom's going to have, it's not mom really, but in a way, will have internal bleeding that there's no way to put pressure on it. It's got to have emergency surgery. They got to cut the fallopian tube, clamp those vessels. Okay. So again, fallopian tubes, uterus, fundus means the top of it. And then cervix is the opening to the uterus from the vagina. This is normally pretty much closed during pregnancy. And then actually there'll be a mucus plug that develops right here that eventually gets expelled. But you need to know, again, the anatomy of pregnancy. Some of the changes that mom goes through, again, it's 9 months is pregnancy, 40 weeks. And we break them down into 3 trimesters. The placenta is an organ that's going to develop around that growing egg. And that's the organ of exchange between mom and the fetus. That's where the oxygen and nutrients get and waste products go back, things like that. And it goes to the placenta and the baby through the umbilical cord. Now, the blood that's in the umbilical cord and in the placenta, primarily, is baby's blood. So there are 2 arteries, and then there's 1 vein. And the arteries,
Hey, Ron.
yeah.
I'm sorry, I have to go back a little. You said ectopic pregnancies are outside of the fallopian tubes?
No, it's inside, but as it grows, it starts eating into the wall of the fallopian tube, and the blood vessels run right with it.
Oh, okay.
It's inside the fallopian tube. But the word ectopic means occurring in a place it's not supposed to. For example, in the cardiac stuff, we talked about the conduction system where, it goes from the SA node to the AV node to the bundle, down the bundle branches, and then the Purkinje fibers. There's a heart attack going on or something like that. Anywhere down that line in those conduction pathways can be the pacemaker for a beat. And those are called ectopic beats because they're not coming from the SA node. So ectopic means not where it's supposed to be. But yeah, okay. It's inside the fallopian tube.
Thanks.
The thing is, the fallopian tubes at the end, where, let me go back, do not exactly attach here. They actually, the egg gets released. It's almost like a pimple that bursts and the egg comes out. And then this stuff through whatever chemical mediators sucks it up somehow. Now that egg could go outside, I suppose, but it's not going to get fertilized.
Okay, thank you.
But ectopic pregnancies are potentially life-threatening if they're not treated. The woman may not even know she's pregnant. She may only be like a week late on her period. All depends. And some think they're pregnant, but it's an ectopic pregnancy. In an ectopic pregnancy, you can have a positive beta sub, which is the test they do to see if you're pregnant, because it's still certain hormones are being released. All right, so there's two arteries that go to the placenta from the baby's heart out through the umbilical cord, and then one large vein that comes back from the placenta that's got mom's nutrients and oxygen and things like that. As the baby develops, we develop this amniotic sac, and inside that sac is a bunch of fluid we call amniotic fluid. And that cushions, it protects. The baby's actually breathing in and out amniotic fluid as it gets older, okay? And you'll notice here that baby's head is normally down, especially when they're almost full term like this one is here. Sometimes they're not, sometimes they're butt down. And then if they come out that way, then we call it a breech. And you also see it's going to turn when it comes down, okay, and comes out. So what else happens to mom? She gets almost a 50% increase in her blood volume. And there's an increase in her cardiac output and her heart rate. Cardiac output is the amount of blood that you squeeze out per minute. And so because there's increased blood volume, there's increased cardiac output and heart rate. But because of the increased blood volume, her pressure, her systolic pressure will actually go down 10 to 15 points on average, because the pressure doesn't need to be as high because we have this extra blood volume running through her system. As far as the respiratory system goes, there's an increased oxygen demand because she's trying to get oxygen to two beings, right? And she's gaining weight, and there's more demand for oxygen in her body as well. All right, it's a complication not during delivery, but pre-delivery. And it's called supine hypotensive syndrome. Even though we use the word syndrome, we actually know what's causing it in this case. But with all that stuff going on in her belly, it's 20 to 24 pounds of extra weight. And when she's laying flat on her back, all of that stuff compresses the inferior vena cava. Now, the inferior vena cava, remember, is the largest vein in the body because it's bringing everything from the lower part of the body back to the heart. But it's still a vein, so it doesn't have the incompressibility that an artery does. It'll compress. So all that weight compresses, blood can't get back up to the heart. It decreases her cardiac output because now she doesn't have that volume to pump back out. And then symptoms develop, dizziness, her pressure drops even further. And so, and I think I mentioned this before, but what's the fix? It's real simple. We turn her on her left side a little bit. Take that gravid belly, gravid means pregnant, and turn it to the side because, again, the inferior vena cava comes up the right side, okay, to the right of the aorta and the spine. Turn her to the left, it takes the pressure off that inferior vena cava. And within seconds, she's better. So pregnant people or gravid people, we need to tip them on their left side. And it doesn't have to be a lot, just a couple inches. So some of the questions we want to ask mom: which pregnancy is this for you? Okay. The person that says, I'm in labor and it's their first baby, they're not ready to deliver yet, probably, if they call you. If she's had 2 babies or a baby before, or 10, doesn't matter. She says the baby's coming, the baby's coming. She knows. Gravid is a word that means pregnant, okay? So a gravid uterus is a pregnant uterus. It's got a being developing in there. And para is a term we use for the number of live births. So somebody who's pregnant for the first time, they would be a gravida 1, para 0. They're pregnant now, but they don't have any live births. If they're having their second child and there's been no miscarriages, they'd be a gravida 2, para 1. So that's a common language that we use in medicine when it comes to pregnant people. Everybody knows what that means. So gravid is the number of times pregnant, including the current one. And para is the number of live births, okay? And then you want to ask, okay, if you've had kids before, how did it go? Were there any complications? Were there any complications with this current pregnancy? Did your water break, or did you lose your mucus plug, or bloody show, some people call it? That plug that's at the end of the cervix, as it starts to dilate, it can come out, okay? It breaks free. And what are the contraction intervals? Do they have an urge to move their bowels? Okay, because as the baby's head engages and starts moving down, it puts pressure on the rectum, okay? And it gives a sensation to mom that she has to move her bowels. Hopefully there isn't stool in there that she's going to push out during the delivery because it makes a mess. It happens. You need to know the stages of labor. First stage starts with true contractions, not the false labor, Braxton Hicks. And it ends when the cervix is fully dilated. The cervix is fully dilated when it's 10 centimeters in diameter, or roughly a little more, about 4 inches, okay? Once that happens, that's the end of the first stage. Second stage, now the baby's entering the vagina, the birth canal. And then once the baby's out, that ends the second stage. So the baby's born during second stage of labor. Third stage begins once the baby's out and ends once the placenta or afterbirth has been expelled. So you need to know the stages, okay? So again, full dilation of the cervix, contractions get increasingly frequent. And when we talk about how far apart contractions are, they say, well, once it gets around to 2 minutes, you know, that's time to think about staying and delivering a baby. But you need to know how to time those, because it's not from the end of one contraction to the start of another. The interval is from the start of one contraction to the start of another. It's not in between, it's start to start. If that becomes 2 to 3 minutes, then we're thinking maybe, okay? A lot of people say, oh, my contractions, you know, they're 2 minutes apart, but it's one ended and then the next one started 2 minutes later. That's not the interval, it's start to start. Pain gets worse, okay? They're gonna feel like they need to push, and you gotta make a decision, okay? So if all of these things are indicating that it might be coming, the last thing you do is look for crowning, and this is crowning. Now, this is a presenting part showing. In this case, it's a head, which is good. The one thing I don't like is this person's got their fingers there. We don't do that. Use the palm of your hand just to provide a little back pressure to that baby's head, so it's not an explosive birth, because we don't want mom to tear. Most do, but we want to make it as slow as possible. We don't want to keep the baby in, but just put your palm up there, and hopefully it'll come out nice and easy. Babies come out normally face down. That's called a vertex presentation. And then they turn. As soon as that head's out, they start turning. Okay, and then one shoulder will come out and then the other one will pop out. And I remember Dr. Daniels used to say, you get a little bit of head, you get a little bit of head, you get a little bit of head, then you get arms, legs, feet coming out. You know, because once that head's out and the shoulders, the rest of it pops right out, because the head is the biggest part of the baby. And once that's out, the rest of it pretty much goes through. Once in a while, you'll get a kid that's got linebacker shoulders. You may have to gently guide their head down just to help that shoulder pop out a little bit, but normally you don't have to do that. And never, ever, ever pull on anything. We don't pull on this kid, period. Okay, let him come out on his own or her own. Word about the placenta. Obviously, umbilical cord, see how thick it is? And you can almost see the blue from the big vein. It's harder to see the two little arteries. But at this point in time, this one's clamped already. Okay. There's no big rush to clamp the cord and cut it. So don't worry about that right away. Okay. The other thing is, this looks like a handle. Don't pull on it. If the placenta is still adhering to mom's uterus, for whatever reason it didn't detach yet, or you're just time inflation makes you think it should have come out by now, you pull on it, and if it's still attached to mom's uterus, you're going to invert her uterus, and it's called prolapse uterus, and that will probably kill her, because the blood vessels in the uterine muscle, if these are muscle fibers, my fingers, you can see it, and this is a blood vessel, it goes perpendicular. So when we contract the uterus, it contracts down on those blood vessels. If we all of a sudden open it up, those blood vessels are going to bleed freely. There's no way to clamp them back down. So never, ever, ever pull anything out of a mom, okay? So hopefully it's going to be a normal delivery. Most of the time when we get called, they're fast, okay? That's the reason they called. They didn't have time to get to the hospital. Support the baby once it comes out, okay? The other thing is keep mom low. Put her in the lowest surface you can, probably a floor. Up on a bed might be a little difficult because it's going to be soft, and you've got to have your hands and knees up there and all that. Get mom as low as you can. Put the blankets and the sheets underneath, etc. Once the baby's out, assess the airway. We used to always suction a baby, but we don't now unless we have a reason to believe there's some sort of an airway issue. And if you do, you start with the nose because they're nose breathers, and then you can suction in the mouth and use that ear bulb syringe. And note the time of birth. If you think it's an imminent delivery, stay where you're at and do it. You don't want to deliver a baby in the back of your ambulance for a couple of reasons. One, you're bouncing. Your driver's going to probably be scared to death because they're not an EMT. And if it's your first one, you're going to be scared to death, but you can't let mom know you are. We don't want them swerving through traffic and all this. You're trying to catch this baby because the babies come out, they're slippery. They're covered in amniotic fluid. They have this white slippery stuff on them called vernix. It's real easy to drop a baby. So keep mom low. If you have to, do it at the house. And the other thing is you don't want to have to, fill out a birth certificate that says the baby was born on Washington Street between 4th, 5th, and 6th Streets, right? So, all right. Big thing for the baby, a couple things. Keeping the baby warm is one of the top priorities, okay? We're gonna dry the baby off with towels, and that does a good thing. I call it encourage, where it's stimulation. It's stimulation, and it's gonna encourage that baby to cry. We want babies to cry, okay? And discard any of the wet blankets that's used, put another warm, or hopefully warm, but another dry blanket around them. And then ambulances are also required to carry what's called an infant swaddler. And it's basically aluminum foil. So you have the blanket around the baby, wrap that foil around that blanket, and then wrap another blanket around the foil. What you don't want to do is wrap foil around the baby. Blanket first, then foil. I actually had a kid come in that was born out in the field, and all they had around them was the infant swaddler, and that kid was losing heat. And when they get hypothermic, especially babies, it screws up their enzymes, and it's really hard to get them back up, and they can get in big trouble by getting hypothermic. Remember, they're wet, they're covered with bloody mucus and vernix and all this other stuff. And when they come out, they're blue. They're cyanotic, okay? I don't care what you moms say. Every baby when they're born is ugly. Every baby. 3-4 minutes later, they get cute, okay? But when they come out, they're ugly, okay? They're covered with crap. They're blue. and they're not happy. Okay, hopefully they're crying, but they will pink up. And it might take a while for their hands and feet to pink up, but hopefully their chest and belly pink up, within 5-10 minutes. All right, so the big thing with the umbilical cord is, you got to remember, that's baby's blood in the umbilical cord and the placenta that's still in mom, okay? So the one thing you don't want to do, did anybody see the movie Roots way back when? Where they held the baby up when it was born? You don't want to do that because that's baby's blood going back down the cord into the placenta that's still inside mom. And you're going to make the baby hypovolemic. Conversely, if you have mom up on a bed and you're down on the floor with the baby, it's going to make the baby hypervolemic because more blood's going to go into the baby. Keep them about roughly even, okay? After the cord stops pulsating, that means the baby's heart is no longer sending blood to the placenta, all right? That means the whole fetal circulation in that baby's heart is now flipping. Because remember, all the oxygen and nutrients coming back from the placenta was coming up a vein, okay? So that heart has to, that valve in there has to close. It's called the foramen ovale. Once that closes, then the cord will slowly stop pulsating. Once that happens and it's fairly flat, okay, then we can go ahead and clamp it and cut it. But there's no big rush to do it. You don't even need to do it until the placenta comes out, actually. So our OB kits have steel clamps. Some of them have umbilical tape, like a shoestring type thing. So one clamp about 10 inches, and then another one about 3 inches closer to the baby, and then you can cut it in between. And again, keep baby and mom around the same level. If the kid is not responding appropriately, it's not really crying, or it's very, very weak, the big thing is drying, warming, and tactile stimulation, that rubbing encouragement stuff I talked about, flicking the soles of the feet, that sort of, no slapping butts like they used to do in the movies. We don't do that. And if you need to, you can do blow-by oxygen. Take a pediatric mask, hold it near the baby's face. Maybe a little oxygen will help them get going. If you have to, you can bag them. Chest compressions, if their heart rate gets to 60. Okay, if it gets down to 60, we do chest compressions. Okay, let the placenta expel naturally. Again, don't pull on it. Let it come out on its own. What you're gonna see is, if you've already cut the cord, all of a sudden you'll see the cord looks like it's getting longer. And that means the placenta is on its way out, okay? If mom will allow it, let her breastfeed. And there's a couple reasons for this, but the big one for us is when mom breastfeeds for the first time, her body, her immune system will excrete a hormone called oxytocin. And oxytocin is what causes the uterus to contract. And we want that uterus to contract. We want those blood vessels to clamp, right? So putting a baby to breast really assists that. Now, not all moms are going to be breastfeeders, but, and the other thing you got to remember, it's not your baby. You don't pass it around the crew, okay? It's not grandma's baby, it's mom's baby, okay? Baby goes back to mom. We can place sanitary pads over the vaginal opening. And once the placenta has expelled, we can do a uterine massage. And women really love this because it hurts. But you're gonna take your fist and the fundus, which I said was the top of the uterus, you can feel it. It feels like a big grapefruit type sensation in there once the baby's out. And you wanna, don't use your knuckles, but use your hand to massage that. That'll help shrink that uterus down too. That'll decrease her bleeding, okay? Because she's gonna continue to bleed. In a normal delivery, there's about almost 500 cc's of blood that'll come out, okay? And that's normal. And if the bleeding doesn't slow down, then you may have an issue. Maybe she retained part of that placenta in her uterus, so it's still hanging on by a thread for some reason, causing some bleeding, things like that. And then ongoing assessment, like any patient, but in this case for bleeding, okay? Complications, cord, baby's head comes out and you can see the cord around the neck. In most cases, you can just take the cord and slip it over the head. Be careful when you're pulling, you don't want to tear it. But that cord's got to come off around the head for the baby to finish being delivered. Sometimes you'll get there and the presenting part, when you look for crowning, is the amniotic sac. And it looks like a sac, like a fluid-filled sac sticking out. Really simple. Take a 4x4 gauze and tear it. It'll tear, and then you'll get the gush of water. Stand back, okay? Breech presentation, that's when the butt comes out first. I never forget my first one. Well, I've only had one. But I'm looking and this thing's starting to come out and I'm thinking, oh my God, this kid's got a split head. You know, and some babies are born, it's called anencephalic, where they only have part of their head. And I thought this was what it was, but it was a breech. I just didn't recognize it as a butt because it's small, you know. Breeches will come out, they should come out fine. If for some reason the breech comes out, you get the butt come out first, then the legs, and then the arms, but the head seems to stay stuck, okay? Get mom's butt up in the air and let the baby hang, and that usually will flex and make a smaller area to come out through that vaginal opening. If for some reason you do that and it's still stuck and baby's acting funky, because remember, baby's head is still in there and so is the umbilical cord. And so baby's head could be pushing on that umbilical cord, and that's going to distress the baby and could kill it. If the head is truly stuck, there's only 2 times we can put our hands inside mom, and this is one of them. If the head is truly stuck, you're going to have to go in and push the presenting part or the baby's head away from that cord so it stays pulsating, okay? And then get them to the hospital. Meconium staining. Sometimes the babies are stressed in the uterus. Sometimes they just get older kids, and they have a bowel movement because, again, they're breathing in and out amniotic fluid. They're also ingesting it. And so that digests in their digestive tract, and they could poop out their first bowel movement. Now, if you've been a parent, you know what the first bowel movement's like. It's terrible, stinky, terrible, tarry, yuck. So if that happens while they're still floating around in the amniotic fluid, they have the chance of breathing that stuff in, and it can get in their lungs. So we kind of worry about that. If you see a dark greenish stain to the amniotic fluid, if you see the amniotic fluid or the mother reports that, that's called meconium staining. That's the kid that you're going to suction their nose and mouth when they come out. We want to get that stuff out of there, or they're going to get aspiration pneumonia. The other case where you can put a hand in is a prolapsed umbilical cord, which means the cord comes out first. Again, baby can't be born if the cord's out, okay? So it gets squeezed between the baby's head and the vaginal opening because baby's head's engaged. Cord is going, well, actually, I think there's a picture of it here. So baby's head, cord's out, squeezing that, baby will die. So you gotta be careful. Get mom's butt up, or our local doctors want you to get her in a knee chest position, get her up on all fours, get her butt up in the air. And then you're gonna, again, slide your hand in just enough to push the baby's head away from that cord. Okay? We wanna keep that cord pulsating. Otherwise, baby doesn't make it. So some other things, we could see some pre-birth bleeding. Hopefully they've had prenatal care and they know that there's something going on already. We talked about the ectopic pregnancy. There's a couple of conditions that can happen. One's called preeclampsia and the other one's eclampsia. And preeclampsia is when mom gains an excessive amount of weight. Her hands and feet are swelling. All pregnant ladies swell, but we're talking about massive swelling. Their blood pressure goes up because remember it's normally going down. And the other thing that we wouldn't know is that they have a lot of protein in their urine. So that's like a toxic situation. It's mom's kind of rebelling against the baby that's growing in there. The problem is with all this massive swelling, it can also cause swelling in the brain. And so hopefully they know they have preeclampsia and they're being treated for it. If they have a seizure, that is now called eclampsia. And it's got like an 80% mortality rate. 80% of the people that seize from this die. Now, they could have a seizure disorder and have a seizure. That's different. This is somebody who has preeclampsia that then seizes, okay? Nasty, nasty. Hopefully they have prenatal care and they're being monitored for that. So that seizure is eclampsia. Less than 24 weeks gestation. It's a spontaneous abortion or a miscarriage. Treat mom for bleeding and that sort of thing and supportive care. Placenta previa, instead of the placenta growing on the side of the uterus where it normally would be, it's actually growing down over the cervix or over part of the cervix. So again, if they have prenatal care, everybody gets sonograms nowadays, they're gonna know, okay? And they monitor it, and at some point they'll do a C-section to get that baby out. This is another reason why we never stick fingers in. You know, we're not going to go and see how far dilated that cervix is. That's not part of our scope of practice. And if you had a placenta previa and you stuck your fingers in there, you just poked a hole in that placenta. That's not good. Placenta previa, very little bleeding with it, but there is bleeding with it as it is if the cervix is growing, opening, I should say, during labor, it'll bleed. But it's placental bleeding. So mom doesn't feel pain with that, okay? In a placenta abruption, what's happening is the placenta is probably in the right place, you know, higher up in the uterus, but for some reason it's separating early in abruption. And mom will have pain with that. And the thing is though, because it's creating a pocket, blood never gets down to the cervix to come out. So there's very, very little, if any, bleeding with an abruption, but there's a lot of pain. With placenta previa, there's bleeding, but mom doesn't have pain. And this would be these both would be third trimester primarily, okay, maybe late second. So, last slide. You gotta know the anatomy, all those structures we talked about. You need to know the 3 stages of labor. You need to know what questions to ask mom so you know how to make a decision if you're gonna stay and play or if you're gonna transport, okay? You need to know the postpartum care of mom. You need to know the care of the newborn. And you need to know how to handle the complications that we discussed, you know, breaches and prolapsed cord and things like that. Any questions on this review from those other videos?
Ron, I have a question.
Yep.
With eclampsia, is there a possibility of having a stillborn, or that has nothing to do with the baby? That's just the mom.
Say the beginning.
With eclampsia, when you have a seizure during it, does that have any effect on the baby, or?
Yes, because mom will die probably before you get to a point where they can do an emergency C-section.
Okay.
I've had several stillborn cases. One was with a lady I knew, which was really sad. I had another one where a girl had been beaten up and 2 days later delivered a dead baby. Those are really sad, sad things. Sad, sad things. And if you have we didn't talk about, but premature birth, you know, they're able to save kids that are like a pound nowadays if they get to the right care. So be aggressive with them, keep them warm, you know, blow by oxygen, get them to the hospital so they can be taken up to children's, or, you know, really quick. Anything else? Nope. All right. Well, thanks guys for taking 45 minutes out of your day. And we will see you tomorrow night. Have a good night.
Thanks, man.
Uh-huh.